All right, this is part 2, chapter 15, injuries to muscles and bones, picking up where we left off. So when we talk about extremity injuries, by themselves, these things are typically not life-threatening. That is, unless there's excessive bleeding present. If an artery is severed or just such a loss of blood, that can cause a life threat. But most of these extremity fractures or just, these injuries from this are typically not life-threatening. Now, sometimes, depending on where you are and what you're doing, you may be the only trained person at the scene of an accident. So you need to be able to react quickly and react competently. So make sure, while you're at the station or wherever you're using these skills, that you can, quickly and competently apply these principles in any situation. So when you talk about doing some of these type of skills, you may want to think about different, positions you may find someone in. You may find someone sitting, you may find someone lying prone, find someone lying supine. So a lot of different positions, and how will you, competently apply one of these splints on someone's leg if they're lying prone or something to that effect. So, typically it does take 2 people to splint most limb injuries adequately. One person to stabilize, one to support, stabilize and support, and then one to apply the splint. So, those are things you're going to need to think about. You may need to address, and give someone some very clear, concise directions on how to do these things and how to be able to work as a team in these situations. So head, let's moving around now. Injuries to the head, so the skull and the brain. So severe head injuries, spinal cord injuries, they can result from lots of different kinds of trauma. These injuries are common causes of death. Now, if not fatal, they can lead to irreversible paralysis and even permanent brain damage. So, we want to be thoughtful about that, depending upon the energy that's transferred and the damage that's done. Now, within the skull, we talked about before, we had the cranium, we had some facial bones. So the cranium being that 4-bone shell that protects the brain, and then those facial bones give form to the face, furnish frontal protection for the brain. Here's what we're talking about. So you see the cranium, and you see the lower jaw and the upper jaw. So mechanisms of injury, head injuries are going to be common with certain types of trauma. So between the skull and the brain, you have some CSF, so cerebrospinal fluid. And what that does is it cushions the brain from some direct flows. And you see it right here, cerebrospinal fluid, CSF. So a direct force can injure the skull, obviously can injure the brain inside. Indirect can also cause some injuries as well. And spinal injuries often associated with head injuries as well. So that force of the direct blows to the head is often transmitted to the spine, and that can produce a fracture or even a dislocation. So, all patients with head injuries, they must have the cervical spine immobilized to protect the spinal cord. Now, in a closed head injury, bleeding, swelling within the skull, it can increase pressure on the brain, and what that does is that leads to some irreversible brain damage and death. Remember, it is a closed circuit there, kind of a closed package. There's nowhere for anything to go. So it's a cavity that has no growth in there. So once you start having some bleeding, some swelling, all of that, there's nowhere for that to go, and it ends up just causing some damage. So an open head injury, that usually bleeds profusely, and then severe open head injuries are serious, but they're not always fatal. So you do want to look at the nose and the eyes and the wound itself to see if any blood or CSF is seeping out. And then in severe cases of open head injury, brain tissue or bone might even be visible. So we see here kind of some different injuries. Have everything from kind of a whiplash injury to direct force, closed and open. Signs and symptoms: confusion, unusual behavior, unconsciousness, nausea, vomiting, blood from the ear, decreasing LOC or decreasing level of consciousness, unequal pupils, paralysis, seizures, external head trauma, so bleeding, bumps, bruises. So here's signs of a head injury. You have raccoon's eyes, which is what you see over here. And then you have, these are battle signs, so paraorbital ecchymosis is what we're talking about here. So these are all signs that there could be damage within the brain, some serious brain damage. Raccoon eyes look like a black eyes that develop after a fist fight, and then battle sign appears as a bruise behind one or both ears. Now, what are we going to do about it? So immobilize head in the neutral position. Obviously, we're going to maintain an open airway, so jaw thrust maneuver here. We know we don't want the head tilt, chin lift. We need to be prepared for suctioning, support their breathing. As soon as O2 becomes available, we need to probably put that on the patient depending upon what their O2 saturation is, and then monitor circulation. Determine whether blood or CSF is seeping from a wound or from nose or ears. Control the bleeding, dry sterile dressings, examination, and then arrange for prompt transport. Now, facial injuries result from following types of incidents. So motor vehicle crashes in which patients' face hit the steering wheel or the windshield, and then assaults and falls, lots of ways for you to have facial damage. Severe damage to the face and facial bones can cause bleeding and collapse of facial bones, which in turn can definitely lead to an airway issue. So if they have facial injuries, we should probably also suspect a spinal injury as well. That energy can continue to move. So facial injuries are rarely life-threatening, but if the airway is obstructed, it can certainly become life-threatening. Now, treatment of these things. What are we going to do? Immobilize head in the neutral position. And then, of course, A, B's, and C's, as we've said, make sure you're cleaning the airway out, using suction or maybe a finger sweep to make sure that we have everything out of there. So supporting breathing, circulation, control bleeding by covering the wound, kind of doing the same thing. So more along the lines of just that general supportive care. Now, if these measures don't keep the airway clear, or if you're unable to control severe facial bleeding, then we can log roll the patient onto his or her side, keeping the head and spine stable and rolling the whole body as a unit. So we can roll them, as you see here, this log roll. We can do that, and allow gravity to work, that kind of recovery position that we've talked about in the past. Now, injuries to the spine. These spinal injuries can cause irreversible paralysis. So a displaced vertebrae, swelling or bleeding, all that stuff can put pressure on the spinal cord and damage it. So in severe cases of spinal injury, the spinal cord can even be up to being severed. So if all or part of the spinal cord is cut, as we can imagine, those nerve impulses are not going to be able to travel to and from the brain, which then tells whatever end organ it is that it's not going to work properly, which could obviously be a real problem. So without the conduction of these nerve impulses, that patient is going to be paralyzed below the point of the injury. Now, the injury to the spinal cord high in the neck, that paralyzes the diaphragm and can result in death. Gunshot wounds to the chest or abdomen can produce spinal cord injury at their level. Falls, motor vehicle crashes, stabbings, all of these are common causes of spinal injuries. And then if you suspect a spinal injury, if they have sustained high energy trauma, then you can suspect a spinal injury as well. Now, common causes of these things: athletic collisions, diving injuries, gunshot wounds. We've mentioned some of these. Falls of greater than 3 times the patient's height, hanging, motorcycle crashes, motor vehicle crashes, and that is with certain conditions. So, patient is ejected from the vehicle if they're unrestrained, if the speed's more than 40, if there's intrusion into the passenger compartment. That can certainly be a cause kind of for alarm. Now, to determine whether a patient has sustained an injury to the spinal cord, we need to talk to the patient and then do a examination. So we want them to kind of tell us about any point tenderness, to let us know where any pain might be. And we don't want to move them. During our examination, we don't want to move the patient. We want to be extra careful and then, take our time to where we don't cause any further damage. Now, signs and symptoms of these spinal injuries: certainly lacerations and bruising and all of that over the head, neck, or spine. Tenderness over any point on the spine. Pain in the neck or spine, or pain radiating to an extremity weakness. Loss of sensation, loss of bowel or bladder control can certainly be one. Some signs and symptoms. So place head and neck in a neutral position. One of the things we're going to do for them, we're going to stabilize the head and prevent movement of the neck. We're going to work on the airway. We get back to these A, B's, and C's. So we're going to use a jaw thrust maneuver if we need to. We're going to clear the airway, and then we're going to put O2 on if they fall within the boundaries of that. Now, a spinal cord injury may paralyze some or all of the respiratory muscles, resulting in abnormal breathing patterns. So breathing using diaphragm only is called abdominal breathing, and that's not something that's going to work real well for the patient for long terms, obviously. We want to make sure we're still going back to those A, B's, and C's. So monitor circulation and then pulse movement and sensation. Examine and treat other serious injuries, and we don't want to move the patient unless it's necessary to perform CPR or to remove him or her from a dangerous environment. So assist in mobilizing them to a long or a short board, depending upon whatever transport service uses, and then arrange for prompt transport, obviously. Now, there is that skill drill, 15-9, is how to stabilize the cervical spine. We'll work on that. And then motorcycle and sports helmets. In most cases, helmets don't even need to be removed. Helmets are frequently fitted to be snug and actually cradle the head. So these things can be secured directly to the spinal immobilization device. So you should remove part or all of a helmet only under two circumstances. One is when the face mask or visor interferes with adequate ventilation or with your ability to restore an adequate airway. So when part of a motorcycle helmet interferes with ventilation, the visor should be lifted away from the face. In case of a football helmet, the face guard should be removed. In most instances, this exposes the face. When the helmet is so loose that securing it to spinal immobilization will not provide adequate immobilization of the head, that's another reason that we would remove that. So loose helmet can be removed easily while the head and neck are being stabilized manually. And the chest. So chest cavity contains the lungs, the heart, several major blood vessels. Cavity surrounded and protected by the chest wall, which is made up of ribs, cartilage, associated chest muscles. You may not uncommon to find fractured ribs in these kind of trauma patients. So even a simple fracture of one rib produces pain at the site, and you'll find that your patients will probably have some difficulty breathing. But multiple rib fractures, that results in significant breathing difficulty. So the patient may not be able to breathe deeply enough to take in adequate amounts of oxygen, which can be a problem. So rib fractures may be associated with injury to those underlying organs that they're protecting as well. So to determine whether a rib is bruised or broken, we can apply some pressure to another part of the rib. Pain in the injured area indicates a bruise, crack, or fracture. So if injury is to the side of the chest, place one hand on front of the chest and the other hand on the back and squeeze gently. Check an injury to the front or back of the rib cage. Put your hands on either side of the chest and squeeze gently. Now your curriculum tells you about pushing in on ribs and all of that. To me, the thing is, if people have rib pain, we just believe that they have rib pain. We're not going to do anything different. We're not going to treat anyone differently, whether they have bruises, fractures, or anything. So be really thoughtful before you start putting your hands on people, and especially before you start applying pressure to something that could cause more problems. Now, a flail chest. So 3 or more ribs are broken in at least 2 places. So you can see here's what we have. We have another word where you see flail chest is flail segment. So this segment right here, you have 2 or more ribs broken in 2 or more places, and it's gone up to 3 or more ribs broken in at least 2 places. That's called a flail chest or a flail segment. And it does not move with the rest of the chest. Because of the pressure of this cavity, as the chest expands, these pieces actually sink down. And they actually have what's called paradoxical motion. So when the chest expands and rises, those pieces are actually going down and vice versa. They reverse. So as the ribs go down, those go out above the chest. So several problems with that is, as you can see on your slide, it decreases the amount of oxygen and carbon dioxide exchange in the lungs, as well as there's trauma that's done to potentially to nerves and large vessels, and it can be a real problem. It also is very painful and can potentially be life-threatening. So if we don't want to restrict the movement of the chest, this is something that's weird. It's changed 2 or 3 times over Of course, the time that I've been in EMS, at one point we used to put sandbags on people's chests, which I cannot imagine that ever seemed like a good idea, just to hold those things in place. And then we splinted them with a bulky dressing. Now we've decided to go on and just allow them to be. You can have them lay on that side potentially to kind of stabilize things, but it sounds like it would be horrible to me. But what we'll do is we'll use positive pressure in the event that they need help kind of stabilizing their breathing. So if they're having difficulty breathing, we don't want to attempt to restrict the movement of the chest while they're inhaling. So it may be helpful to support their breathing with positive pressure ventilations, and then monitor some port ABCs, and then of course prompt transport. So penetrating chest wounds. Now, if an object, so we're saying like a knife or a bullet or a pencil or a pen or whatever, penetrates the chest wall, air and blood escape into the space between the lung and the chest wall. What happens with that is air and blood can cause the lung to collapse. So obviously lung collapse, that greatly reduces the amount of oxygen and carbon dioxide that's exchanged and can result in shock and death, as you can imagine. Having a downed lung is not a good thing, a collapsed lung. So some of the things that we're going to talk about is we want to quickly seal that open chest wound with a material that will prevent more air from entering the chest cavity. So first thing you're probably going to do is just use your gloved hand. Now, if it's more difficult for a patient to breathe after you seal the wound, you can uncover one corner of the occlusive dressing to see if breathing improves, because like we talked about before, you can actually burp that wound and allow air to escape. So administer O2 if available, if you have it, meaning like you have it's in your protocols and everything. If a knife or other object is impaled, do not remove it. This comes down to one of those things, we're not going to remove stuff. So seal the wound around the object with a dressing to prevent air from entering the chest, and then stabilize whatever it is, that impaled object. And then any chest injury that results in air leakage and bleeding, that requires prompt transport, obviously. Patients with severe chest injuries require rapid transport. It should be pretty obvious. Conscious patient with chest trauma should be placed in a sitting position. That would help ease their breathing a little bit. And then unless you must immobilize the spine or treat for shock, help them assume whatever position eases their breathing. So summary, covered a lot of stuff here, musculoskeletal injuries. So direct force, indirect force, twisting force, so open and closed fractures, dislocation, sprain versus strain, 3 basic types of splints, rigid, soft, and traction. Then head injuries, facial injuries with airway obstruction, open injury of a head usually bleeds profusely. And if you suspect spinal injury, don't move the patient. So that's part 2 of chapter 15, injuries to muscles and bones. So we'll talk on chapter 16.